Let's quickly talk about some of the direct pharmacologic targets of the RAAS system and just kind of put this all together. So the first one on here is probably the highest yield. These are going to be the Ace inhibitors. Now remember, these are going to inhibit the angiotensin converting enzyme. Okay, so I just kind of drew this out here just so that you can see it in simplified terms. And, there's certainly more details to this. We already talked about the things that, will stimulate the JG cells, like, decreased perfusion to the afferent arteriole, low sodium concentrations of the macula densa, beta-1 stimulation, right? I'm just going to put on here beta-1 because we'll talk about this in a minute. So those are the big three things. But again, let's just look at where do the ACE inhibitors fall into this. So the ACE inhibitors are going to inhibit ACE right here. So the ACE inhibitors are going to act at this location. Okay, so by inhibiting the ACE enzyme, right, you're blocking this step. So you're not going to form angiotensin 2. You're not going to form a lot of aldosterone. You're primarily going to have high levels of renin and angiotensin 1. Okay, so again, that's kind of how these mechanisms work. Everything proximal to that block is going to build up. So again, inhibition of ACE increases in angiotensin 1 and renin, that's what we just said. Decreases in angiotensin 2 are going to be the arrow pushing signs that you're looking for. Arrow pushing mechanisms are huge for step 1. So you want to be familiar with, this pathway and what area is affected. Now, when would you primarily use ACE inhibitors? Again, usually you don't have to pick which ACE inhibitor to use or when to use them on step 1, but you still should have a general idea that, again, they're used for hypertension, they're used to lower the blood pressure, right? Because the RAAS system causes increase in blood pressure. Now, the big thing that I really want you to remember, though, is that they have nephroprotective effects for the reasons that I mentioned. If there's a really high pressure, they can dilate the efferent arteriole to relieve glomerular pressure, which is very important in patients that have diabetes, because patients with diabetes can go on to have chronic kidney disease because of the diabetes. My point is, if you have a patient that has hypertension and has diabetes, you should be looking at ACE inhibitors first, okay, as one of the first medications for the hypertension. Now, just like there's nephroprotective effects, there's also cardioprotective effects. Again, by decreasing the total peripheral resistance and decreasing the preload, you can prevent some of the ventricular remodeling that would have to happen in the heart. Okay, so there's also protective effects. We already talked about their effects in heart failure. The RAAS system is a vicious cycle in heart failure. You can manage that by attenuating that RAAS response using ACE inhibitors. Now, you might be saying, okay, well, what about these angiotensin receptor blockers? You can absolutely also use these. Okay, now the ACE inhibitors, the way that you can distinguish these, the ACE inhibitors, you'll see there's usually going to be a pril at the end, lisinopril, captopril, and enalapril. The angiotensin receptor blockers are going to have a sartan here, valsartan, losartan. Okay, so you're usually going to see that. So that can help you distinguish them. Now, you might be saying, well, what's the difference? Don't they do the same thing? Angiotensin receptor blockers specifically are going to block angiotensin's binding to its receptor, just like the name says. Okay, so if this is the angiotensin 2 receptor, which is specifically the type 1 receptor, so angiotensin 2 is going to mediate most of its effects through the type 1 receptor, by the way, and the angiotensin receptor blockers will essentially block this step. So I'll put ARBs here. They're essentially going to block that step, which means that you're not going to decrease the levels of angiotensin 2. This is something that's very confusing for people. The angiotensin 2 levels in a patient on an ARB or in a board question, they should still have high levels of angiotensin 2 because the RAAS system is still stimulated. You're just not getting the effects of the RAAS system because you're blocking the receptors. You're not decreasing the amount of angiotensin 2 formed. Here's the thing that's confusing. If you give somebody an ACE inhibitor in a board question, their angiotensin 2 levels should be low. If you give them an ARB, the angiotensin 2 levels should actually be high, right? So because you're not decreasing the angiotensin 2 formed. That's the big point to remember here. So the angiotensin 2 levels will generally tend to be normal or elevated. Again, receptor blockade of angiotensin 2 type 1 receptor. And again, similar uses to what we just saw, hypertension, nephroprotective effects, cardiopulmonary effects. Now, a couple other differences between ACE inhibitors and ARBs. In general, the ACE inhibitors are notorious for causing a dry cough. Now, I don't have enough time to kind of go through all of this with you, but I'm just going to kind of give you a quick overview. Essentially, we have our high molecular weight kininogen that goes on to form bradykinin. Now, this bradykinin is essentially broken down into kind of like an inactive metabolites here by the angiotensin converting enzyme. Okay, so angiotensin converting enzyme is allowing the bradykinin in our body to kind of get broken down into inactive substances. If I give them an ACE inhibitor, I'm also going to affect this pathway. So if I block this, I'm going to have an increase in bradykinin. Increases in bradykinin can cause two major side effects. The first one, this is very common for patients on ACE inhibitors, they can have a dry cough. If they tell you in the board question, patients on an ACE inhibitor, they have a dry, non-productive cough, you can switch them off the ACE inhibitor and give them an angiotensin receptor blocker. In board questions, in the academic world, ARBs should not cause cough. In the real life, they can, but it's a lot less common than an ACE inhibitor. So you can take somebody off the ACE inhibitor and put them on an angiotensin receptor blocker, because the angiotensin receptor blockers are not blocking ACE. They're blocking angiotensin 2 binding. So they won't have effects here at bradykinin. It's important to know these pathways, because a lot of times you're not necessarily asked which drug to switch them to, but you're asked why. You're asked about the pathway. Okay, that's the important part. Now, the other major side effect here is going to be angioedema. This is a more rare side effect, and I don't want to talk about this too much in this video, because this is really a discussion for a future video. So we said the bradykinin can cause a cough, which would be more common, but it can also cause angioedema. Okay. And this is pretty severe if it starts to close off. If you'll have swelling in the face or the lips, and it can eventually close off the airway. And this is going to be particularly problematic in patients that have deficiencies of enzymes in this pathway, which I'll talk about in a future video, but one of them is going to be the C1 esterase inhibitor. Okay, so these patients that have C1 esterase inhibitor as a complement inhibitor, they're already predisposed to angioedema. Now you give them an ACE inhibitor, they go into angioedema. Okay, so that's also a very classic board question. We'll talk about more of that in another video. I don't want to get too off track here. And then we have the direct renin inhibitors. So again, we're just going back to our pathway. At what step in the pathway would a direct renin inhibitor affect? A direct renin inhibitor would affect this step here. So renin would not be able to cause the conversion of angiotensinogen to angiotensin 1. And in general, when you're thinking about the direct renin inhibitor, aliskiren here, this is generally not going to be used as a first line. And again, you don't have to know a ton about this, but if you give the patient an ACE inhibitor and ARB, they both don't work, you can go to a direct renin inhibitor. It's more important to know where it affects the pathway, though. It's primarily going to be up here. It's not inhibiting renin formation, but it's affecting the activity level of the renin. So in other words, you might still have high levels of renin if you give somebody a direct renin inhibitor. It's just that the renin is not going to be functional. That's also important to remember. That can be very confusing. Now, neprilysin normally inactivates ANP and BNP. Okay, and you might be saying, okay, well, that's not good in heart failure, right? Those are the two that we actually need to compensate for the RAAS system. But if you give somebody a neprilysin inhibitor like sacubitril, what you're doing is you're essentially doing the opposite. You're inhibiting this target so that you have more ANP and more BNP. And that's what you want. You want the natriuretic peptides to offset the RAAS system. Now, the problem here is these drugs like sacubitril, they'll actually also activate angiotensin 2. So to counter that, what you can do is you can give a combination. You can add a valsartan to this. So you can give valsartan, right, sacubitril. And so what that does is the sacubitril will primarily be responsible for increasing the ANP and the BNP, while the valsartan is going to tone down, it's going to inhibit your angiotensin 2. So you can inhibit the RAAS pathway and also stimulate the natriuretic peptides at the same time. So it's kind of like a double effect if you use them together. If you didn't use them together, some of the effects that you're getting from stimulating ANP and BNP using sacubitril would actually go away by also stimulating angiotensin 2. So that's why you'll see valsartan, sacubitril used together. And again, I wrote that here, used in heart failure when combined with angiotensin 2 receptor inhibitor. Finally, the last thing on here is going to be your beta-1 blockers. And you might be saying, well, what does metoprolol have to do with this RAAS pathway? Remember, in the very beginning, I told you that beta-1 receptors stimulate juxtaglomerular cells. If you block beta-1 receptors at the juxtaglomerular cells, right, you're not going to stimulate the RAAS pathway. And that's essentially what selective beta-1 blockers do. Now, there's also non-selective beta blockers, but you probably wouldn't want to use those beta blockers because then you're going to get a lot of mixed effects at beta-2 receptors. So if we really wanted to just focus on this pathway, we would use a selective beta blocker like metoprolol, nebivolol, esmolol, atenolol. We'll talk more about the differences in these in the pharm lecture. I don't want to talk about, everything about beta-1 blockers here. I just want to let you know that they actually plug into this pathway. And again, they can be used in coronary artery disease to decrease myocardial work. Okay, and they can also be used in many different types of cardiac arrhythmias, atrial fibrillation, etc. We'll talk more about this. And just remember that they primarily can cause bradycardia, bradyarrhythmias, and we can see findings like PR prolongation, AV node blocks, etc. And like I said, we'll talk more about this in the future. The last kind of thing I want to say here is just remember, when we're talking about the ACE inhibitors, the angiotensin receptor blockers, the direct renin inhibitors, these are all going to be contraindicated in pregnancy. Okay, they can cause renal malformations or renal impairment and risk of harm to the fetus. So we want to avoid them in those situations.